I'd like to welcome you to our webinar, Untapped Resource, How Inpatient Stay Data Optimizes Risk Adjustment Programs. My name is Sean Forster, and I'll be the moderator for today's discussion. During the presentation, all participants will be in a listen-only mode. We do, however, encourage you to ask questions during today's webinar. Please submit your questions using the questions window located on the right side of your screen. Type your question into the box, click send, and they'll be sent directly to a meeting organizer to queue for the Q&A session we have at the end of today's webinar. Should you encounter any technical difficulties, please also utilize the questions window to describe your issue, and one of our support staff will follow up with you to troubleshoot. By the end of the hour, attendees will understand the importance of cultivating a robust data set. More specifically, we're going to discuss how this data impacts the 5 topics that are listed here. We'll close by telling you a little bit about how our understanding influences what we do at CO, and also have some time again for a Q&A session. With that, we invite you to sit back, relax, and enjoy today's presentation. Our speaker today is Susan Hedge, VP of Operations, who brings with her more than 30 years of experience in healthcare. Prior to joining CO via ClearVision, Sue worked for Blue Shield of California, where she led a team of systems analysts and programmers overseeing day-to-day operations, analyzing workflow, and managing resources. She has extensive experience in business systems analysis, data security and control, and strategic computing. Sue is also part of SciCare Systems, supporting their healthcare billing organization, where she managed the computer operator and data control teams. With a strong customer service orientation, Sue is instrumental in understanding the needs of our customers and ensuring that our production activities align with their requirements. She currently oversees all aspects of the quality initiatives, from coordination and selection each year to certification and implementation. Thank you all for joining us today, and with that, I'll step aside and turn it over to our presenter. Sue?
Well, thanks, Sean. Hello, everyone. I'm glad to be here to discuss how inpatient stay data is a vital piece of optimizing your risk adjustment program. So here are the agenda topics we are looking to cover today throughout our presentation. So why do we want to collect inpatient data? We really want to collect any data which is allowable for risk adjustment, and inpatient data falls into that realm. It supports a number of different areas across the health plan. In the regulatory realm, we've got to report any applicable diagnosis codes to the highest level of specificity, and they must be substantiated by evidence in the medical record. So this is where chart reviews come into play to confirm documentation of conditions that may not already be captured in the plan's claims system. Then to sustain the viability of our healthcare system, we need to make sure the reimbursement for care provided is appropriate. In addition to Medicare Advantage, with the passage of the Affordable Care Act, health plans must ensure accurate data for the member population in order to optimize their financial, quality, and clinical outcomes. On the patient care front, it's fantastic to have that 360-degree view of a patient's conditions. There's a subset of the Medicare population and the elderly who don't go to the doctor on a regular basis, and perhaps a hospital stay occurs as a result of that. That particular hospital stay is going to be rich in diagnosis codes, not just for that specific patient stay, but for addressing previous issues, perhaps chronic ones. Financially, for risk-adjusted lines of business, a complete data set is critical to ensure appropriate reimbursement for the care provided. And then lastly, as more lines of business move toward risk adjustment models, it's important for plans to have that core competency around accurate diagnosis documentation and data gathering to support optimal care and reimbursement. Okay, who should be collecting inpatient data? Any risk-adjusted line of business, definitely Medicare Advantage. This is a fully risk-adjusted line of business. The higher a member's risk score, the more dollars are allocated to pay for their care from CMS to the plan. And there can be advantages to doing this for commercial exchange marketplace and managed Medicaid as well. So for marketplace, some dollars are redistributed amongst the plans based on risk score versus premium revenue and how your plan performs relative to other plans. But in the end, you're going to fare best if your risk score is high. And then for managed Medicaid, there are a number of different reimbursement models, some that factor in health status and medical and or drug diagnosis information would benefit from a program of this type. All right, data drop-off. As we know, we operate in a care delivery system where there are many handoffs of information, patient to provider, vendors to health plans, and regulators. As a result, there's many opportunities to miss and drop data along the way. So here's just a few examples. At the hospital, let's say a patient had 28 diagnosis codes for a particular hospital stay. A standard UB billing form, one can only enter 18 diagnosis codes. So in this case, we've got 10 codes that's not going to make their way to the plan or CMS. Also at the hospital during billing, perhaps the billing area staff is told to focus on the fields which get the claims paid. They might only enter the primary diagnosis field and no others. So you've got to drop off there. So now we move to the plan during claims processing. Some health plan claim systems have capture limitations of a certain amount of diagnosis fields, and it might be under 18. So even if the hospital is sending you 18 codes, if your claim system can't capture that many codes, again, you've got to drop off. And then in claims adjudication, sometimes there are points in a month where a claims manager may say, we've got to get this production out, and to make production move faster, they ask that their staff enter less diagnosis codes to make production move faster. So again, you've got to drop off. Okay, now we move to an EDI vendor. If a plan gets data feeds directly from an EDI vendor of inpatient diagnosis codes, there could be edits in place that you don't know about, which could be causing data to drop. And it's my opinion that somebody at the plan should always be designated to work with an EDI vendor to not only know what edits are in place, but be actively working those error reports. Now let's look at optimizing care. Having a view into inpatient stay data provides additional insights for primary care physicians, which can improve patient care. If you have a software application where you can tie your physicians into this information, all the better. So the patient-provider interactions. During doctor visits, patients often discuss why they are there, or they discuss their most recent illnesses, and they might forget inpatient admissions from several months back. But if a doctor has information on inpatient stays, it can really supplement that patient-provider interaction. Quality management. Inpatient stay information can provide early warning indicators for better medical and quality management. Having the additional data from the inpatient stay allows providers and plans to engage members in specific care or disease management programs, which may have been uncovered during that inpatient stay. And then predictive analytics. Having this data can help predict future patient needs and plan for potential complications. This level of precise diagnosis information, it's key to understanding each patient. And then coding accuracy. Inpatient data supports accurate and, just as importantly, complete coding, quality of care and compliance with regulatory requirements. And then the system limitations, we addressed those in the previous slide. Hand in hand with supporting care improvements, inpatient data completes the picture for optimizing revenue. Determining payment, we know that in most cases it costs more to treat a chronic condition than a non-chronic condition. Chronic conditions must be substantiated at least yearly for each member in order to ensure consistency of revenue to the plans. So CMS pays based on evidence that resources were intended to treat a condition and not just because somebody has the condition. So what happens if a member refuses to see his PCP? If the member happens to have an inpatient visit during a year where they did not see their PCP and then the plan pulls in this inpatient data into their mix and in its entirety, they may likely see an uptick in their payment for this member. Cash flow. If conditions are missed, there's an opportunity to correct them, but corrective review cycles are long, and this has a negative implication from a cash flow perspective. In the case of Medicare Advantage risk adjustment, waiting until the final adjustment to amend data at certain points of the revenue cycle could mean waiting 18 months for reimbursement adjustments. And then closing care and revenue gaps. It has been reported that anywhere from 30 to 50% of chronic conditions are not reported from one year to the next. Inpatient data can help improve these closure rates. And then rule-out codes. Inpatient stays can include rule-out codes. These codes are only captured at a facility, and they rule out possible health issues to determine actual diagnosis, because in a hospital, resources are expended while trying to rule out a condition. And these codes will count as valid for 1 year for that member. Okay, let's look at a few specific examples here of the financial benefit a plan could realize from inpatient data. In this example, we assumed a base county rate of $800 per member per month. Assuming your plan identified some of the more common hospital-based conditions in just 10 patients, you could be looking at an annual revenue impact of more than $140,000. Now multiply that across plan populations of 10,000, 100,000, and 1 million. It's not hard to see how inpatient data pursuits result in a strong ROI. And we often see ROIs that range from 5 to 25 to 1. And we actually have seen some triple-digit percentages as well throughout the years. So if you're selected for a RADV audit, let's talk about how inpatient data is a benefit. The member inpatient medical record is generally considered to be the best record to substantiate a RADV audit. Hospital coders are certified each year, and because of the regulatory oversight, we know this results in greater coding accuracy. These coders are taking the inpatient charts and deriving the codes from them. We have all heard that CMS has introduced the Medicare Recovery Audit Program, which expands audits of MA plans and at-risk providers. The goal of the program is to identify instances of overpayment. We can expect increasing demands for data validation and vendor oversight. As an industry, we're required to supply the most accurate and complete diagnosis coding and medical record documentation. Our providers have also have obligations for use of diagnosis coding standards and medical records, reporting all conditions that exist on the date of an encounter. Having complete information, knowing where your system and process issues are, ensures you're better prepared in the case of a RAC or RADV audit. An important part of setting up your inpatient data pursuit project is determining your filtering strategy. Some plans pursue 100% of their inpatient stays. Others choose to prioritize their outreach. Your filtering strategy needs to match your risk adjustment program and project objectives. Some important things to consider are your parameters. Are you looking to pursue all of your inpatient stays and retrieve the maximum number of diagnoses and HCCs? Or are you looking for a strong ROI with more criteria in place to create a more targeted strategy? Then looking at providers, perhaps you design your pursuits to only focus on a subset of providers instead of all of them. Are there certain providers that most likely have submitted only a subset of codes? It's important to understand provider response rates. If you've got limited resources or time, you might want to first pursue providers that are more likely to respond in the required window. Then consider coordinating this effort tactically with other initiatives going on within the plan. Are there certain patients that are part of another retrospective initiative where inpatient stay diagnoses are already being captured? You want to coordinate between retrospective efforts to guarantee efficiency and ensure that you're not duplicating efforts. Think home assessments or general chart pursuits. Understanding your EDI, vendor data transfer, and claim system rules and edits can help you focus your efforts. For example, if you know your claim system only captures a certain number of codes, then you might want to start with pursuing patients with that upper claim limit of codes, with the assumption that there may be more beyond that. And then lastly, you could prioritize outreach by considering how data is transferred between the plan and the provider. Perhaps pursue data from hospitals with whom you don't have an electronic transfer channel in place and focus on the smaller volume facilities. As you begin to think about setting up your project, you'll certainly be faced with the question of how to most efficiently get the job done. So I'm going to spend a few minutes talking about the sourcing strategies. They're going to differ depending on the time and resources available to you within your plan. And there are a few ways to source a project like this. You could handle it 100% in-house. This would mean using your own resources for analytics to pull your target population, the provider initiation, and ongoing outreach, all the data entry, any internal reporting, and the submission of codes to CMS, which is the file creation of a RAPS file or an EDPS file. Or you could work with a vendor like CO and outsource the entire project. This approach allows you to gain the benefit of our economies of scale. In outsourcing work, you should also think about payment options, which could work for you. Do you prefer to pay per pursuit or by response only? And then there are other options as well. For co-sourcing, many of our clients do a combination of both. How the work is divided, again, is up to your program objectives, resources, and time. You could divide by geography or by function. For example, doing the filtering in-house, but outsourcing provider engagement, data collection, and data entry. You could divide by provider affiliation. For example, insource the owned entities and outsource the contracted entities. Divide by volume, or divide by data transfer methodology, where maybe you handle the electronic transfer in-house and outsource the paper transfer. So whichever sourcing strategy you select should align with your budget and timeline realities. So we've covered a lot of information about the benefits of inpatient data collection, how it supports care improvement, revenue optimization, and supports compliance and auditing. We want to talk about how to put this all together into an action plan for setting up a project. We have also incorporated some best practices along the way. So the first step is to define what you're trying to accomplish. What are you hoping to achieve, and how are you going to measure success? This is going to influence your filtering strategy, your resourcing strategies, and your metrics. Your risk score should accurately reflect the health status of your membership base. And then you want to define your milestones and timeline. You need to build your work plan. In order to do this, you have to assess what sleep date am I working toward and which dates of service am I pursuing. This is going to drive your timeline. Be sure to factor in time for analytics to develop your target list, multiple provider touches, time for data entry, reporting, and export file creation. And then your sourcing strategy. Are you insourcing, outsourcing, co-sourcing? This is dependent on your internal staff and funding resources, as well as deadlines. And then your response rates. You're going to want to be sure that your process accommodates data received in all possible channels, paper, electronic, fax. Optimizing response rates. Another thing to consider is minimizing provider abrasion. Medical record retrieval is very labor-intensive for providers. This problem gets exacerbated when multiple departments are reaching out to the same providers for information, such as when a risk program and a quality program are going on at the same time. So try and coordinate your efforts across departments and across lines of business for a given facility. The best practice is to conduct outreach throughout the year and not to bombard those providers with requests for information all at once, especially in that fourth quarter. And good to maintain provider profiles in-house to support resulting forecasts, including facility contacts, request preferences, data transfer methodology, response seasonality, and response rates. And then when you are developing your target pursuit list, be sure to align your filtering strategy with your overall project goals. Do you want to cast a wide net or maximize ROI with a very targeted pursuit? And then think big picture. Inpatient data pursuit should be one component of a comprehensive risk adjustment program, complementing your other retrospective and prospective tactics. Be sure you are coordinating initiatives and not duplicating efforts. With regard to compliance, in your program design, consider whether you can build in self-audits to identify program weaknesses. A properly designed program can also leverage this outreach to support network accuracy requirements, such as we have built in an address validation and correction program. And then measure your results. Be sure you have metrics to measure your success. This could include measuring response rates, speed, and method of response, incremental codes captured, financial implications, risk score, and ROI. Your risk score should reflect the health status of your membership base. As you're working through your process, remember, we are happy to help you. CO, formerly ClearVision, has been conducting inpatient pursuits since we first opened our doors 9 years ago, and we have pursued millions of records. Our clients have strong ROIs and have benefited from our facility relationships, our economies of scale, and lessons learned. We have flexible pricing options, including per member per month, flat fee, per pursuit, or response. So with that, I thank you for your time, and I'd like to turn it back over to Sean for the Q&A portion of the presentation.
Fantastic. Well, thank you so much, Sue, for walking us through those slides. As you mentioned, we're now entering our question and answer session, and by my watch, we have about 4 minutes or so to get a few questions done. So As a reminder to folks on the call, please submit your questions via the questions window on the right side of your screen, and then we'll be able to see those coming in and answer them. One question that we always seem to get that I can answer even is, will this presentation be available? The answer is yes. We have been recording today's call, and you will receive a follow-up email from us with a link to that recording. It will also be posted on our website as well. So be on the lookout for that. Looks like we haven't had any questions come in so far, though we did have questions come in through the registration process. So I'm going to start with one or two of those before we answer some of the live questions coming in. So one question, Sue, that we had to do around the timing of inpatient data pursuits, and if sort of how long does a typical pursuit cycle take? Are they defined limits, or is it an ongoing process? Maybe talk a little bit around that approach.
Sure. So if a client were to come to CO and ask us to do a pursuit for them, we would do a 90-day project for you. And what we would do is a 30, 60, and 90-day mailing to each of the facilities that were in question, per se. And so we would work with the plan to identify the best targets to go after, and these would be members that we'd want to get more codes for, and then these members were seen at a certain facility. We'd target those facilities, and so we would definitely do a 90-day pursuit with. And
great. Let's see, we did have a question just come in from the audience here, and it had to do with the typical response rate that you would see as a part of that project. Do you have any,
so in that 90-day, we tend to get an average 75% rate in the first 60 days, and we're seeing 92% overall, which is awesome.
Yeah. Can't argue with that. And let's see, we do have a question here, and it's around, looks like that this asker already has a relationship using some analytics for risk adjustment, and if they are in that situation, would they also benefit from using data pursuit services from CO?
I would think so. So the risk adjustment piece, this is inpatient pursuit, so that definitely could be outside of whatever the client is doing for risk adjustment. So we'd have to learn more about that, but I would certainly think that this could definitely be something that we could work.
Sort of a part of that whole risk adjustment program.
Correct.
Process, right? You may use different internal
Absolutely.
resources. You may work with other partners, but this can be part of that.
Absolutely.
And the quiver of tools that you use.
Yes.
Let's see. I think we have time for one last question here. You touched on it, I think, during your slides as well, and around having this be a one-time approach or an ongoing thing that people do year after year. Maybe you can speak to some of the benefit there around not having this just be a one-time thing.
Right. So we have a lot of clients that definitely do this on a regular basis because they know that, as I said in the slides, there are all these regular drop-offs of data, and that never stops happening. So that's why our clients do this on a regular basis. And so just doing it one time is not going to fix that problem. And that's why they come back to us year after year to help them with this process.
Well, thank you, Sue. I think we're right at the bottom of the hour here. We did have a couple more questions come in, so we'll respond to those offline. So you'll get a follow-up over email. email. But we wanted to close today's presentation by telling you just a little bit more around CO and our company. So CO DX Max is the solution that we talked about at the end here really comes from a merging of two mission-driven companies, Clear Vision and CO Health Analytics, and really excited about this partnership that complements both of our company's strengths. For more than 14 years, CO and our acquired companies have really partnered with organizations to drive care reimbursement optimization through our leading healthcare analytics solutions and services. And globally, CO provides our healthcare partners with really actionable insights through our deep expertise, flexible analytics, innovative services like CO DX Max, and technology that drive measurable outcomes improvements. I really think it's that concept of outcomes being measurable that we really try to strive for. We extend into many critical areas, including population health, payment integrity, risk adjustment and care management, like we talked about today, opportunity analysis and incentive design, consumer engagement, network performance, and commercial effectiveness. So just a little bit around what CO is all about here. And in closing, I want to just thank everyone for taking the time to join us today. If you want someone from CO to contact you about anything you've seen today, please visit the Contact Us page on our website, and someone will follow up with you shortly. And with that, I'd like to thank Sue again for walking us through that really great content, you all for joining us, and that concludes today's conference. So thank you, and have a wonderful day, everyone.